going to be variable.
Well, thank you. So at this point, we'll transition to the manufacturer comments and discussion section of the morning. I'd like to invite the manufacturers to join us, Ted Buckley, Pani Subaya, and Maria Sullivan. Please come to the main table in the front. And as you're transitioning up here, I'd remind you to please state any conflicts of interest prior to delivering your remarks. And also remind you that we are timing this, and you'll each have 5 minutes. And Milan will show you the timer as you go. We'll begin with Ted Buckley.
My name is Ted Buckley, and I'm the head of government affairs and advocacy for Braeburn. Braeburn's primary mission is to fight the opioid addiction epidemic. The work we are doing can make a difference in the lives of patients who often shoulder the burden of treatment themselves. We aim to reduce stigma by raising awareness that opioid use disorder is a chronic brain disease best treated by evidence-based medication-assisted treatment. Together with counseling and support, Braeburn's next-generation medicines aim to support patients focusing on the reintegration of their lives with their families and communities. Braeburn's long-acting injectable regimens, currently under review by the FDA, will be administered directly by a healthcare professional. Therefore, healthcare professionals and patients are able to maximize medication adherence to the prescribed treatment while potentially minimizing the risk of abuse, misuse, and diversion. I'd like to thank ICER for providing Braeburn with the opportunity to publicly comment on its MAT evidence report. Overall, Braeburn believes that the process and research assumptions in which ICER engaged are deeply flawed, so flawed that it calls into question the findings of the report. ICER consistently ignored comments and information that we provided to them, even when ICER had requested the information. Examples include, but are not limited to, long-term discontinuation. We provided ICER with information from a poster entitled Long-Term Safety, Tolerability, and Effectiveness of CAM 2038 Weekly and Monthly Buprenorphine Depots for Treatment of Opioid Dependence, a U.S., Australian, and European Phase 3 study, which shows 73.6% of participants receiving the full 48 weeks of treatment. However, ICER chose not to include it. Further, this informative study seemed to meet the criteria for inclusion in the analysis based on Section 3.2, but was excluded for unclear reasons. Number two, mean percentage relapsing of illicit opioid use while on CAM 2038 after remaining abstinent on treatment. We provided ICER with the 2018 JAMA Internal Medicine article entitled Weekly and Monthly Subcutaneous Buprenorphine Depot Formulations versus Daily Sublingual Buprenorphine with Naloxone for Treatment of Opioid Use Disorder, a randomized clinical trial, which shows the superiority of CAM versus sublingual buprenorphine with naloxone on the cumulative distribution function with respect to the proportion of opioid-negative urine samples for weeks 4 to 24. ICER chose not to include it. Number three, ICER's treatment of the topic of diversion. With respect to diversion, ICER has stated that there are no robust published estimates on diversion or misuse of MAT therapies. However, there are multiple published studies in high-impact peer-reviewed journals which highlight diversion, misuse, and abuse as frequent occurrences with prescribed oral buprenorphine and methadone. Additionally, we provided ICER with a link to the raw data from SAMHSA, as well as other data sources, that demonstrate that oral buprenorphine and methadone are among the most commonly misused prescription opioid medications. Oral buprenorphine and methadone are misused by 766,000 and 261,000 Americans, respectively. Oral buprenorphine and methadone are currently the fastest growing misused prescription opioid medications, currently ranked number 1 and number 2, respectively. However, ICER has chosen to ignore this data on oral MAT and seemed to suggest that there would be no advantage to a healthcare provider-administered therapy with respect to misuse, abuse, diversion, and accidental pediatric exposure. At the very least, ICER should have taken existing data into account and provided a reasonable assumption of future benefits. By ignoring the data entirely, ICER raises the concern or appearance that the conclusion of the report was preordained from the beginning. Concerning the process, the time period for commenting on various steps of the process was inadequate. Number two, the limitations put on the length of submissions, usually 3 pages, call into question whether ICER was actually seeking meaningful input, which would lead to a broader consideration of all viewpoints with the expectation of a higher value report. Finally, as a part of the open input period, ICER asked for the names of key opinion leaders as well as relevant third parties that they should contact to help determine the scope and direction of the study. The deadline for submission was April 23rd. The draft scoping document was released 3 days later on April 26th. 3 business days seems like it is insufficient time to contact the key opinion leaders as well as relevant third parties, discuss the topic with them, and then incorporate their feedback into the draft scoping document, which is the basis for this entire exercise. Finally, this morning, there were some questions about our trial, and the answer that was given mischaracterized our data. We urge the committee to read the Lawful study, and we are happy to answer questions about our input points and results. Thank you for your time.
Thank you. Now I'd like to ask if ICER staff or the panel has any comments or questions.
Yeah? No. Okay, great. Perfect. Okay, your questions about the study we did not consider in table 5, the line 2, about the mean % of negative urine samples confirmed with self-report. I just spoke with my colleagues who did the data extraction, and this corresponds to one of the publications you mentioned we did not include. We did include it. So I don't really understand your comment as that we did not exclude what we should have included.
No, I'm sorry. We said that you did not include the secondary endpoint, which demonstrated superiority.
We did include the secondary endpoint that you mentioned from weeks 4 to 24.
That's correct.
We did include it in the report.
Okay. Now, please go ahead, Doctor. We have our Chief Medical Officer here.
I'm sorry, I actually don't want to have a debate back and forth in the middle of the presentation.
Okay.
If you look at the report, I mean, I looked over to my colleagues saying, didn't we include that? And we did. People can look and see.
And I think the distinction was made between primary and secondary endpoints, which is critical for clinical trials and critical for us to be able to distinguish as we deliberate. Any other comments from ICER staff?
I just wanted to comment on the SAMHSA data that was mentioned on diversion and switching. We were aware of that data. However, it's not in a format that is able to be adapted to the cohort that we were looking at. So there was no way to use that on a patient level to talk about diversion. The other thing that was missing from that is there's not good data on the switching to other opioids that may occur at the same time.
Any comments or questions from the ICER panel? Steve.
Has your company conducted any cost-effectiveness analyses from the trials that you've conducted on the medication for either other nations or for use here in the United States? And if so, can you characterize them?
To my knowledge, we have not.
Okay. Thank you very much. We'll now move on to
Thank you.
Ms. Sobaya.
Good morning. I'm Pony Sabaya. I'm a neurologist and Chief Medical Officer at Indivior, Inc. Thank you for the opportunity to participate in today's discussion. I would like to begin by acknowledging that the treatment and recovery from opioid use disorder is complex. Opioid use disorder is a chronic disease that is characterized by long-lasting changes in the brain, which leads to intense drug craving and compulsive use with loss of control. In addition to these factors, the patient treatment journey is also heavily impacted by societal considerations, such as social stigma, challenges accessing prescribers and treatment, and difficulty adhering to treatment plans, all of which can lead to relapse. Opioid misuse, abuse, and diversion are also factors unique to the disease that must be considered. For over 2 decades, Indivior has been developing evidence-based medicines for the treatment of opioid addiction. As its originator, Indivior knows that buprenorphine has long demonstrated value in the treatment of opioid use disorder. We also recognize, however, that existing treatments do not meet the needs of all patients, which is why we developed Sublocade, a once-monthly long-acting formulation of buprenorphine. Our goal was to leverage new science and a deeper understanding of the brain to develop a long-acting formulation that delivers consistent buprenorphine plasma levels over the treatment period, resulting in continuous occupancy of greater than 70% of the mu opioid receptors. Now, this is important because this translates into clinical benefits, such as increase in the number of opioid-free weeks and blocking of drug-liking effects if the patient uses illicit opioids. The monthly, rather than daily administration and directly by a healthcare professional improves the likelihood of adherence, as well as reduces the potential for abuse, misuse, diversion, and accidental pediatric exposure. We appreciate ICER's interest in reviewing new formulations of medication-assisted treatment for opioid use disorder. The evidence supporting the value of long-acting buprenorphine formulations is still evolving. In its assessment, ICER recognizes the likely benefits of these formulations and notes their potential to improve adherence as well as address treatment challenges like medication abuse, misuse, and diversion. However, ICER also acknowledges that it could not build these real-world treatment considerations into its assessment due to insufficient data. Indivior recognizes the urgent need for real-world data and is currently conducting several post-marketing and real-world studies, which we look forward to sharing with payers and with ICER in the future. At this critical time in the opioid crisis, interpretation by treatment providers, payers, or policymakers of the conclusions reached by ICER in its evidence report could impact patient access to these important new treatment options. Access to all medication-assisted treatments and counseling is critical at this juncture to ensure that patients get the medical care that they deserve and need, just like the care provided to patients with other chronic diseases such as diabetes. In closing, I would like to offer the following three considerations. First, that we recognize the potential value of long-acting injectables and acknowledge from a scientific viewpoint that it is premature to reach any conclusions on the relative value and cost-effectiveness of these treatments until more evidence is generated in real-world practice. Second, that manufacturers should generate data to support the broader indicators of treatment success in the real world. Lastly, that payers recognize the additional new real-world evidence that is being continuously generated for these treatment innovations and consider this data in their decision-making process as it becomes available. Thank you for your time.
Thank you. I'd like to ask if the ICER staff has any comments.
So, thank you very much for your comments. A question that we've had all through with Sublocade. For each of the other preparations we looked at, it was compared to an active treatment. And I was wondering if you could give us some insight into why, with Sublocade, a different decision was made.
So this was done working very closely with the FDA. And one of the reasons that, first of all, one of the reasons that the way the trials were designed was the FDA, first of all, wanted to have more an objective way of looking at the evidence related to the benefits of these long-acting injectable. And so instead of the patient driving the decision, is there a way that physicians could have confidence in certain plasma levels or objective evidence so that that could be used as a measure of how to treat and how much to treat with. So with that, in conversations with the FDA, it was decided to look at really, to assess that, it was decided to use placebo as the comparator.
Any comments or questions from the ICER, excuse me, the CEPAC panel? Thank you very much.
Thank you.
Dr. Sullivan.
Good morning. My name is Maria Sullivan, Senior Medical Director of Clinical Research and Development at Alkermes. While I'm here today to share with you Alkermes' clinical perspectives on the need for broad access to treatment for opiate use disorder, I'm also a practicing addiction psychiatrist who sees patients on weekends, and in this capacity, I can attest firsthand to the ongoing fierce struggle that people with opioid use disorder endure. I'm also on the faculty at Columbia University in New York City and previously served for many years as an independent investigator for the National Institute on Drug Abuse. Like many of my colleagues who have dedicated our career to helping individuals with OUD, I have been intensely frustrated by the unrelenting growth of this opiate epidemic. Despite this growth, the alarming reality is that less than 10% of individuals with this debilitating disease receive any form of treatment. I think we can all agree that we have an imperative to do everything possible to help address this gap in treatment. The lack of access to evidence-based treatments is especially troubling because we have 3 types of medications approved by the US FDA to treat opioid dependence: buprenorphine, methadone, and extended-release injectable naltrexone. Each of these has a distinct role to play in addressing the epidemic, and it's important that patients seeking treatment for opiate dependence have access to all treatment options, including the long-acting injectables, which improve adherence, so that together with their healthcare providers, they can determine the treatment approach that is best for them during the recovery journey. A growing body of evidence consistently reinforces that medications for opioid dependence, when combined with counseling, are effective treatment options. Yet there is limited awareness of and access to these medications in the treatment community. In fact, less than 3% of treatment programs in the US offer all 3 forms of medication options for the treatment of OUD. These treatment modalities are not interchangeable. Their FDA-approved indications are not identical. Injectable extended-release naltrexone, or Vivitrol, is the only medication approved by the FDA for the prevention of relapse to opioid dependence after opioid detoxification, and it represents a distinct and important treatment option. Some patients enter treatment for opioid dependence seeking to become opioid-free, and for them, Vivitrol is a critical treatment option. There's also a body of scientific evidence from clinical trials and more recently from emerging neuroimaging data that XR naltrexone does reduce craving, both on patient self-report and in experimental paradigms that have focused on cue-induced cravings, which can trigger relapse. Consider the story of one of my patients, whom I'll call Eric. He began using a variety of substances in his mid-teens. By his late teens, he was in treatment for OUD. He cycled in and out of programs for young adults, being detoxed, released, attending group counseling, but never received medication therapy. He also experienced 3 near-fatal overdoses during those years. His mother told me that when he came to see me and began receiving a monthly injectable medication, she was for the first time in 4 years able to find some peace of mind, and her worries about those dreaded middle-of-the-night phone calls began to lessen. Seeing Eric's progress 4 years later, it's hard to quantify the meaning to this patient or his family of having an available treatment option proven to prevent relapse to opioid dependence following opioid detox. Other patients have tried and failed agonist therapy, and for them, antagonist treatment is a vitally important evidence-based option in order to re-engage in treatment. I'm thinking of another patient whom I'll call Sharon. She had seen a practitioner who was prescribing for her a high daily dose of an agonist in an office setting, and she was using a portion of this medication, but she'd been selling the rest to buy heroin, which was her preferred drug of abuse. Her family, upon finding drug paraphernalia, confronted her, alerted the prescribing MD, and with the support of her family, she decided to seek a treatment plan to meet her evolving needs and preference at that point. Together, we determined that a treatment approach, including the use of Vivitrol, would be best. This has supported her continued abstinence for the past few years. Sharon and Eric are examples of the devastating impact of this disease in the context of either no treatment or an initial treatment that proves ineffective for a particular individual, and why it is essential that we do everything we can to improve access to and awareness of all 3 types of FDA-approved treatments. Patients, in fact, deserve to be fully informed, and they deserve access to the full range of treatment options. For instance, pain management in the context of MAD is quite misunderstood. While chronic opioid analgesic use would certainly be a contraindication for a patient on Vivitrol, in an emergency situation, surgeons can and routinely do override the antagonist blockade with IV opioid analgesics. And in the post-op ambulatory period, most clinicians would hesitate to begin prescribing opioid analgesics for a patient with a recent active history of OUD.
Dr. Sullivan, if I could just ask you to wrap
Yes.
up your comments. Thank you.
While it's commendable that ICER has taken on this very timely issue, we're concerned that a comparative effectiveness analysis of OUD medications may potentially distract from the urgent necessity to focus on the individual's treatment needs, as well as past treatment history and specific setting of care. Any comparative analysis must also consider the cost of not offering treatment, which can have such negative implications in both healthcare costs and human life, and in closing, the urgency for accessible, comprehensive, patient-centered care for people with OUD has never been more timely or pressing. We have the power to make positive change to a broken addiction treatment system and to foster open and equal access to all evidence-based treatments, to stem the tide of this unprecedented devastation, and to help patients, their families, and the thousands of other individuals who are directly affected by opioid use disorder. Thank you.
Thank you. Any comments or questions from the ICER staff?
Thank you very much. Okay, great. Thank you very much for your comments. I find it interesting that you talk about withdrawal and the brain imaging studies. I don't think anything has been published on this yet. However, it's interesting if this would be confirmed that Vivitrol indeed reduces cravings, which may not correspond to the clinical experience people have, but
May I respond?
may not correspond to what clinicians are telling us and what's published up to now. So if indeed this is coming up, that's great. I was wondering, a question for you. I think the main challenge for Vivitrol is the protocol for opioid withdrawal. How do you get patients to the state of opioid withdrawal? Do you have any comments on that, on best practice, on guidelines, on?
Yes, it's an excellent and important question. What we saw in the recent CTN51 trial, the XBOT trial, was that there was a wide range of methods attempted and great variability in success. Their overall success rate was 72%. That was in an inpatient setting. In fact, there's been a growing body of work, particularly in the last 3 to 5 years, looking at induction strategies. To be brief, I'll simply say that that is an area that Alkermes has focused on, has published in, and there are several independent researchers who have published on this as well. If I might put it in a nutshell, one can use an agonist taper for a brief period, 7 days. One can use a strategy of low-dose oral naltrexone with ancillary medications, and there are also recently published non-opioid, non-benzodiazepine protocols. It depends on the skill and comfort of the practitioner, but there is a multiplicity of options. The most important is the confidence and skill of the practitioner. If I may simply add that there are several studies, several clinical trials published showing immediate and sustained reductions in craving, and there's work out of UPenn looking at neuroimaging under conditions of XR naltrexone.
Any questions from the CEPAC panel?
I had a question sort of similar to Dr. Kogut's previous question for Dr. Buckley, but for the other two companies. Have your companies conducted cost-effectiveness analyses?
Oh, I'm sorry. Yes, so certainly with respect to cost of Vivitrol, there have been some, and there are some analyses ongoing. I think one has to reckon with the tremendous cost of untreated OUD. And the cost of Vivitrol relates to issues of manufacturing a long-acting injectable, which is a costly process, and there are, as you might imagine, a number of quality restrictions and checkpoints in that. There is also, I'm aware of some ongoing work which will soon be published in this area, and I think we'll have further comments later in the day on this.
All right.
And so we have conducted cost-effectiveness model using network meta-analysis approach, but it did, that was shared. It did look into broader considerations as far as looking at more of the data that was available as far as the number of trials, also looking at also the other contextual considerations, and so that was positive in favor as far as cost-effectiveness.
Sorry, cost effectiveness of which comparison?
I'm sorry?
Cost effectiveness of which comparison?
We compared it again with the other standard of care that's available, and then that was the main comparator. So some could be no use, but could also be orals as well.
Okay.
Stephanie.
Great, thank you. My question is about naltrexone. Do you have any data or any studies in the works looking at the use of that agent in patients with active hepatitis?
I'm aware of the work of Sandy Springer at Yale, who has looked extensively at its use in HIV patients and patients with hep C. And in brief, what her findings show is that the use of XR naltrexone in that context promotes adherence to the anti-infectious disease or antiviral treatments. She has also intriguingly shown reduced viral loads in patients on XR naltrexone, and she has argued that this is consistent with improved immune status.
And just to be clear, and those are in patients with opioid use disorder, correct?
Yes, she has looked at both alcohol and opioid use disorder and presented and published in both populations.
Thank you.
All right. Well, thank you very much. We'll transition now to public comments. I'd like to invite our public commenters to the center microphone. First, Frederick Ryan from the Arlington Police Department. And as you introduce yourself, please state if you have any conflicts of interest with industry. Yes, thank you.
Good morning, ladies and gentlemen. My name is Frederick Ryan. I'd like to thank the ICER Advisory Committee for their important work and for allowing me the opportunity to comment today. Again, my name is Frederick Ryan. I serve as co-chair of the Police Assisted Addiction Recovery Initiative, also known as PARI. PARI is a national nonprofit organization made up of nearly 500 law enforcement agencies in 32 states in our nation. And we employ, in the Commonwealth, we employ about 25 certified recovery coaches and clinicians corresponding with law enforcement and EMS in public safety agencies here in the Commonwealth. Our mission is to change the conversation in law and policy around substance use disorder from one of arrest and incarceration to one of increased access to treatment and the expansion of access to all approved evidence-based treatment therapies. Our position is that inhibiting access in any way to any of the evidence-based options currently on the table can have devastating and potentially fatal consequences in our jurisdictions. Now, I'm here to offer the real-world perspective, and as a man who had difficulty with quantitative analysis and research methods in graduate school, I'm intrigued by this whole conversation. But while my comments today are in my capacity as the co-chair of the Police Assisted Addiction Recovery Initiative, you should also know that I serve as Chief of Police in Arlington, Massachusetts, and as a Commissioner on the Commonwealth's Harm Reduction Commission. By increasing knowledge and access to evidence-based treatment options in our community in Arlington, we've driven down the accidental overdose death rate by more than 50% in our jurisdiction. Simply stated, without all of the options on the table, all three evidence-based options, we would never have achieved these results. It's estimated that only about 4% of the U.S. population suffering with substance use disorder get access to medication-assisted treatment therapies. And, you know, we could have a whole other conversation about the socioeconomic and racial disparities around access to treatment, but that's another conversation. We've learned early in our community efforts to address the opiate epidemic that the self-imposed barriers to success were many. Now think about it. In 2015, when we rolled out our program, police departments were prohibited from dispensing nasal naloxone in their communities. We did it in violation of whatever regulation it was that we violated. Now today, in 3 short years, it's commonplace and encouraged. I see the draft analysis by ICER as yet another example, as another self-imposed barrier to success. It's Parry's position that any law, regulation, policy, or study that creates additional barriers to success to medication and treatment therapies is a bad thing, and we're extremely concerned that the unintended consequences of this analysis could result in further stigma associated with medication treatment therapies and could have unintended consequences in terms of more confusion among prescribers and their patients. We feel strongly that comparing agonists to antagonists is an apples and oranges comparison, and that no different than a cancer patient working with their oncologist to decide between chemotherapy or immunotherapy or radiation, all of which have different economic impacts. A person suffering from substance disorder should be able to work with their healthcare provider to determine what treatment option is best for their life circumstances and for their recovery journey. And these treatment options are not interchangeable. Further, our initial work on medication treatment therapies with pre-release population in our prisons and jails is yielding amazing results with major favorable economic impact, and the cost savings resulting from patients being effectively treated and maintained on Vivitrol were not included in this analysis. Lastly, I'd like to share a few anecdotes to support our position, because I know scientists love anecdotes, right? Due to the demographic and high incidence of opiate use disorder, we've done a lot of work in the fishing industry with fishermen in Plymouth, Gloucester, New Bedford, and other fishing ports. And, take, for example, the fisherman who gets deployed for days or weeks on a fishing vessel. One of the treatment options is automatically removed from the table, and a patient such as that is unable to be maintained on methadone maintenance during their employment. We've worked with law enforcement agencies and public health agencies on Martha's Vineyard, where patients on the island simply don't have access to methadone maintenance treatment. And I'm not sure whether the economic impacts of those areas were factored into the equation. In closing, we're going to keep all options on the table and work together to reduce the stigma associated with medication treatment options. The stigma in the addiction community and the stigma in the provider community. I should, as an aside, my wife is a practitioner in women's health. She works with pregnant women with opiate use disorder, and you can imagine the conversations we've had at the dinner table over bottles of wine on this topic. We at Parry go to extraordinary measures to prop up all approved medication treatment therapies. And while I know that this study did not examine the economic impact of diversion of oral buprenorphine, an issue that many in law enforcement like to moan about, we at Parry would support ICER's decision not to focus on the economics of such diversion, but rather to focus on the economic impacts of a culture and a society where there's wide availability to all evidence-based medication treatments, and a culture where those suffering with opiate use disorder can manage their chronic illness no differently than any other chronic illness. I thank you for your work and for the opportunity to comment today. Thank you very much.
Thank you, Chief Ryan. Next comment from Madeline Reinert, Mental Health America. And please do state if you have any conflicts of interest, and I'll remind you to keep your comments to 5 minutes. Thank you.
Good morning. We have one conflict of interest, which is that Mental Health America receives more than 25% of our funding from healthcare companies. Mental Health America is the nation's leading community-based nonprofit dedicated to addressing the needs of those living with mental illness and to promoting the overall mental health of Americans. Our work is driven by our commitment to promote mental health as a critical part of overall wellness, including prevention services for all, early identification and intervention for those at risk, integrated care services and supports for those who need it, with recovery as the goal. Firstly, Mental Health America thanks ICER for assessing the comparative clinical effectiveness and value of several new options for medication-assisted treatment of opioid use disorder. Additionally, because one of the key goals of our organization is to support recovery, we support ICER's acknowledgement that the primary aim of treatment in this case is recovery rather than cure. We also support ICER's acknowledgement that people experiencing OUD present with important mental health comorbidities, and each of the medications discussed in this report should be used in combination with counseling and psychosocial support. In conducting the cost-effectiveness modeling, MHA asked that ICER consider cost-effectiveness from the perspective of both a generic payer and a public payer, or Medicare and Medicaid. Medicaid and disability Medicare are the largest payers for adults experiencing opioid addiction in the United States. ICER even acknowledged in the report that healthcare costs were modeled based on those for a commercially insured population, which may not be representative of the real-world OUD demographic. We know that poverty and disability contribute to the development of behavioral health conditions such as OUD, and behavioral health conditions create burdens that can cause poverty and disability, which creates a cycle. Effective treatment and management of behavioral health conditions, on the other hand, can break this cycle and allow individuals to reach or maintain a level of community participation that positions them to stay on or purchase commercial insurance and not require public benefits, which dramatically reduces costs and increases cost effectiveness from a public payer perspective. While ICER's cost-effectiveness modeling does currently include increases in productivity, the measure that we are proposing is different. With Medicaid and disability Medicare, increases in productivity beyond a certain threshold uniquely reduce healthcare costs as the individual disenrolls entirely or never requires coverage in the first place, impacting ICER's primary cost-effectiveness calculations for these public payers. For example, if someone experiencing poverty is on Medicaid and receives medication-assisted treatment for OUD, and as a result of that treatment is able to begin recovery and improve productivity enough where they no longer qualify for Medicaid or can secure private insurance, that specific increase in productivity will reduce costs and dramatically increase cost effectiveness of medication-assisted treatments from the public payer perspective. Where there might not be adequate evidence to allow for modeling of this, even scenario analysis would benefit the field. Cost-effectiveness analyses can include estimates regarding how many people a treatment would allow to increase their productivity to the point that they were able to disenroll from Medicaid or disability Medicare. Further, by making such analyses common practice, it can shift the paradigm for how CMS and state Medicaid agencies view costs and benefits away from simply trimming healthcare costs and toward making critical investments in human thriving that alleviate poverty and disability, which we believe is a public good, and will ultimately reduce costs as an added benefit. Finally, it is also important that the medications being compared are meant for the same patient population and clinical indication to ensure a valid comparison. This is especially important as this report has implications for access to medication-assisted treatments, and if ICER chooses to assess the comparative clinical effectiveness and value of these medications, we ask that they evaluate comparable medications in terms of clinical indication, treatment goals, and patient population. So thank you so much.
Thank you very much. Our final public comment is from James Andersen, Meridian Research.
Greetings, we're almost at lunch. My name is Jim Andersen. I'm not sure of the conflicts there. I will say that 70% of my income comes from those who are drug addicted. They pay me. And they pay me a lot less than they pay their dealers. The average person I see is shelling out between $100 and $200 per day to people who aren't even paying taxes. So I don't know how you're going to fix that in your voting today. That'll be a good one. To work that, you're going to need some economists. I have experience in all these areas. I do. I appreciate the chief. I use them all. I've run our opioid treatment program now, methadone clinic in Lakeland, Florida for the last 23 years. I've been prescribing buprenorphine for 18 years and 16 years, and the last 18 years I've been involved with corrections and long-term treatment facilities, residential for people with multiple different problems, but specifically mostly now opioid problems in residential treatment. These people are in a diversion program to keep them out of prison. I think that when you're talking here, many of my patients are in construction industry, and I get a lot of construction stuff. And we're talking here about if you're putting a house together and say you've got a dock in the backyard, They may use nails in one spot, they use screws in another spot, they use some staples in another spot, and so forth. And you're going to use different methods to do those things. If you're trying to get a hammer to drive a screw, you've made a major mistake. Likewise, someone may come up with a better way to drive a nail, and called a nail gun. And you can drive a lot more nails in a lot less time with a nail gun. But the cost effectiveness, that has to be worked in, because when I did my ER work, I also took a lot of nails out of people's legs from them shooting themselves. So there are pluses and minuses to all of these treatment methods. And it is up to the clinician, just like all of you, especially our clinicians here, how about diabetes medicines? I mean, in my research, I do half my time is research. I do clinical trials. I'm a principal investigator, and I was principal investigator on the Sublocade trial we knew as RB6000. So I have experience with 30 people just in our one center, taken all the way through, and this is 2 years, because we had a 6-month extension study, open label, on Sublocade. And everybody got a prescription for this stuff at the end to put them back on buprenorphine, naloxone, sublingual films. Well, and the people that I saw after this, none of them had filled their prescriptions. None of them. Okay? This drug is like an auto detox. It goes out of you so slowly they didn't even know it. We had 2 that had the iron bar detox, and we're in jail. We lost them. They were dealers, and we lost them to the study. They were out of window, not out the window, but out of window, and they couldn't come in, but they told us both, say, Doc, this is the best jail detox we've ever had. Didn't even notice it. Didn't even feel it. Okay? Now, when they come out, these people felt like they're no longer addicted. Now, I explained to all of them, you have a number of other factors which tell me that you are up for potential relapse. You are up for this. You are not cured. But if you're doing fine without this, we'll keep seeing you and not prescribing anything until, of course, something comes along. A man invites his heroin-addicted girlfriend back. He's got a good job, making good money now, and now he's back on opiates. He's back in my practice. Another gentleman who will get his first Sublocade shot at 4 o'clock today. I'm doing this in absentia because my nurse that has given over several hundred of these injections will be doing it, and did it for him because he was in the study. And he also did not use after the study was over, until he's in the construction business. Had one of his coworkers who was a heroin addict talked him into using something, and he did. And the first time he used, after all this time of abstinence, of course, he OD'd on fentanyl. Now, he survived, he came back, but he's also a player. He plays with the drug. He got back on Suboxone, so I said, fine, we'll put you back on this. And he did, except that he would go a few days, and then he'd stop for 3 days, shoot up, and go back on his sublingual preparation. No one knowing this. He comes in with a normal drug screen. I used a 14 panel on everybody, and he was fine. He scored well. But when I find out from other people, of course, what he's doing, and he finally confessed, I said, you need to be uninjectable. That's what you need. So this is what I do as a clinician. I take all 3 methods, and I've given 4, I don't know how many hundreds of Vivitrol shots. And it's been a great drug. It's been super. I'm also, I don't know where Braeburn guy went, but I'm a certified Braeburn prescriber as well, so I don't have any difficulty with any of these products.
Dr. Andersen, just want to remind you that your time is up.
My time is up. I want to thank you all for here, and do think of all these things. Hammers, screwdrivers, wrenches, all different. Thank you.
Thank you very much.
May I ask him a question?
Yes, please, Steph.
Thank you. I was curious about the trial that you discussed, and you said everyone at the end of the trial, nobody filled their sublingual prescriptions. And I was curious if that sublingual prescription was paid for as part of the trial.
No, as part of the trial, they got 6 months additional, which was voluntary, 6 months of treatment free. Or they could have had a paid prescription at the end, which would give them 1 month. Now, it's one thing that people with opioid use disorder can do. It's work math. They worked the math. They found it was a lot better off to take 6 months free than 1 month. And so they did get a prescription. And some of them moaned at the end, what do you mean? You didn't pay for this? Oh, I'm sorry. You agreed to this in the beginning 6 months ago. And as far as no one, that's no one that came back to see me, and I was local, so that I had potential contact with these people. I will say, Dan, that one girl who did get her children back, who had been taken away because of her opiate problem, got them back. She said, she came to see me, she said, I did not fill the prescription. Why didn't you? Because when I was on this medicine, I felt like I was no longer using. And I don't want to go back to taking something for something.
Thanks. And just to be clear, so at the end of that injection, the drug was no longer paid for. Is that correct? Okay. And I wonder if that's a barrier as well.
Any other comments by CEPAC panel? Jason?
I had a question for Chief Ryan, if I may. I really appreciated the thoughtful and informative comments, and just congratulations on your community experience, because that really impressive results.
Thank you, Doctor.
You've spoken very eloquently about the benefits of a medical approach to the opioid epidemic versus a incarceration approach, I think is the term you used. And I'm really interested of your opinion in Arlington or in other communities that you've dealt with. You've talked about the barriers to MAT. So what practically, is it in a very real sense, in a community sense, what are the barriers that you perceive that are most problematic?
A lack of knowledge and really ignorance around family units who have a loved one suffering with substance disorder. I mean, I'll give you a real life example. I'm the guy here to offer the real life perspective, I guess. We were in a staff meeting working on a program around our opiate outreach initiative when I was interrupted by my secretary, who came in to tell me that our staff was at a fatal overdose, and the fatality involved the brother of one of our very popular police officers. And he, too, was a law enforcement officer in the correction setting. Now, I typically don't go out to the fatal overdoses, but in this case, it involved a family member of one of our own. And I went out to offer my condolences to the family. And this really sums up and answers your question. And as I offered my condolences to the mother of the deceased, and the deceased was literally on the other side of the wall in a bedroom, she said, we were just so ashamed to admit that our son was an opiate addict. And we were so ashamed and embarrassed to come out to one of the community meetings, because we've had widespread community meetings to educate people about medication treatment therapies. But they didn't want to come out in public because of the shame and the stigma associated with addiction. And it's that stigma right there. I mean, that sort of summed it up for me, that this woman knew that the community she resided in had advanced level sort of services for people suffering with substance disorder, yet the shame and stigma associated with addiction prevented them from seeking that. But also with the treatment community. I mean, we've seen medical practitioners speak, frankly, unintelligently about one therapy versus another. And, from our perspective and our experience across the nation, it's got to be patient-centered and no different than any other chronic illness, and allow a patient to decide with their provider what their recovery journey might look like. I hope that answers your question, Doctor.
Yeah, no, it does. Thank you very, very much. I hope we have a chance later in the policy roundtable perhaps to talk more about the role of education in combating this epidemic. So thank you, sir.
I'm sure that this will be a topic in the policy roundtable for sure.
Oh, yeah.